We're going to start the afternoon with Dr. Robert Thompson, who is a neurogenetics and gene therapy fellow in Florian's program at Mass General. He's a geneticist and metabolism fellow at Harvard Medical School Genetics Training Program. We're really fortunate to hear it. He'll be talking about things that we all have wrestled with, which is there's different phenotypes, as we know, between adrenal insufficiency, cerebral, AMN, and really help us understand a little bit more about the evolution in those phenotypes.
So thank you for that introduction. It's very nice to meet all of you. So again, I'm Dr. Thompson. You can call me Robert. I am a neurogenetics and gene therapy fellow at Mass General. And today I have the pleasure of speaking to you about genotypes, evolutions of phenotypes, and precision medicine and ALD. So first, just want to give a quick shout out to Dr. Eichler and the entire group of the Center for Rare Neurologic Disease, mostly over there. It's been a true pleasure to get to work with all of you guys. And also just a quick shout out to the patients. I texted Christy Higuera asking if maybe like one or two women would be willing to share a picture for my symptomatic female slide. And then, of course, we got an outpouring of like dozens of pictures, which is really cool. So I've gotten to meet a lot of the families, and it's this is my first ALD Connect, and I'm really hope to get to come back. I have no disclosures. So as mentioned, I'm unlike many of the physicians and providers in this room, I'm not a neurologist. I am a clinical and biochemical geneticist. So while I definitely should not be the one that's reading your MRI, I do think a lot about the genetics and how the genetics leads to the clinical symptoms or the phenotypes in ALD. So Dr. Eichler and I thought that maybe it would be helpful for me to talk about some of the terms that we use, things like genotype and phenotype, clarify some of those details, and then hopefully we can tie that back to some of the research that we're doing at MGH and also some of the amazing research we've heard about here. So to get started with that, just as a side-by-side comparison for what a genotype and a phenotype is, I'm going to go into more detail for both of these, but your genotype most concretely is just your family's variant in the ABCD1 gene. A little bit more abstractly, what that means is it's a unique sequence of DNA at a particular spot in your genome or in your genetic code. A phenotype, pheno comes from the term to observe. So technically, a phenotype is an observable trait. Obviously, we talk a lot about the major phenotypes, which are cerebral ALD, AMN and myeloneuropathy, and adrenal insufficiency. But to go into a little bit more detail, so this is an excerpt of a positive genetic test for ALD. Plan on going through all of these one by one. Hopefully that would be helpful. But realizing that there's different amounts of medical and scientific background, and some families are very new to ALD, and some have been around for a long time. Maybe we'll just take a second to talk about the very fundamentals. So what is DNA? What is a gene? What is chromosome, etc.? DNA is the building blocks for your genetic code. It's little stretches of nucleotides, which we label C, T, A, and G. And when a stretch of DNA, when taken together, that has a particular purpose, often in the context of genetic disease, that's for coding for a protein, that is a gene. So then all of your DNA is wrapped up very tightly inside of chromosomes. Men and women, so we have 46 total chromosomes. Men and women are the same in that they each have a pair of 1, of 2, of 3, etc., up until you get to chromosome 22. Where they differ is in the sex chromosomes, and obviously that becomes very important. Men have an X and a Y, women have 2 X's, and that obviously gets super pertinent, which we'll get to. I'm not going to spend too much time on this slide because we've talked about the pathophysiology of ALD ad nauseum at this point in the presentation, but the ABCD1 gene codes for the ABCD1 protein, also called the Adrenoleukodystrophy protein, and this is important. It sits on top of the peroxisome, and it helps to get very long-chain fatty acids into the peroxisome. So if that protein is not working, the very long-chain fatty acids continue to elongate, and then they can become the C24 and the C26, which are the ones that are toxic to the adrenal glands into the nervous system. So built into the term X-linked adrenoleukodystrophy is X-linked inheritance, and so I thought I would talk a little bit about that briefly. X-linked inheritance just means that the ABCD1 gene is located on the X chromosome, and then it's in general passed down from generation to generation. So Depicted here is a pedigree or a family tree of like kind of the most classic scenario that we see for patients in clinic. Squares are male, circles are female, and if the square of the circle is colored in black, that means you're affected with ALD. So generally, it starts with the boy who's diagnosed, and whether the boy is diagnosed on newborn screen or becomes symptomatic with cerebral ALD or adrenal insufficiency, for example. You do genetic workup, and you see in general that the boy inherited the abnormal X chromosome from his mom. The reason why that is true is because men and boys have X and a Y. So you can see that the boy definitely got the Y chromosome for dad, which means that his X chromosome he got from mom. The red X here is signifying the abnormal one. So you can see that mom has a 50-50 chance of passing down the abnormal copy. Often what we see is that you go further back in the generations and you see maternal grandmother was also affected. Maybe someone carried a diagnosis of multiple sclerosis, etc. So this is generally what we see. There are some exceptions to the inheritance being passed down from generation to generation. One of those is called a de novo variant. You may have heard that term be thrown around, but what that means on a new change to the child. There's another term called germline mosaicism, which is a little bit more complex and also very exceedingly rare that I don't think I have time to go through. Okay, so X inactivation. So the difference between men and women, men having an X and a Y, women having two X's, explains the difference in the symptomatology that we have. Because men only have one X chromosome, every single one of the cells in their body is going to manifest the abnormal copy. And this is why boys get adrenal insufficiency, cerebral ALD, AMN, while women in general just get myeloneuropathy with some rare exceptions. But for females who have two X chromosomes, it turns out the cell does not want to see both copies of the X chromosomes. They only want to see one. And so when early on in embryonic development, when just a couple cell stage for the mom when she's in the womb, the cells kind of randomly decide whether or not to manifest one copy or the other. And that's called X inactivation. You can see the abnormal or the inactivated X under the microscope. It's shown here in this white dot, and that's called a bar body. But in general, because this is a completely random process, most of the time, about 50% of the cells that end up in the mom will manifest the good X chromosome, about 50% will manifest the abnormal copy. However, this is essentially on a bell curve, right? So, and it's very possible that really just due to several moments of luck, whether it be good or bad, the majority of your cells can manifest the abnormal copy or the majority of the cells can manifest the good copy. If you're skewing in the direction of the abnormal copy, that seems to be correlated with more severe symptoms. That's something that Jörg Jaspers and Stefan Kemp talked a lot about in their recent paper. But so that's kind of the underlying biology that leads to the clinical symptoms. I thought I would take a moment to talk about this variant nomenclature, which you could see on a genetic test. So when we have a new genetic change, we ask about the C dot and the P dot. C stands for coding DNA technically, but I just kind of remember chromosome, and then P stands for protein. So what this is saying is at the nucleotide number 796, there was a change from a G to an A. And that single change in a nucleotide led to a change in the amino acid. So at the 266th amino acid position, a G, which is also called a glycine, was changed to an arginine. And still to this day, I find it fascinating that you can have a single change in one nucleotide that leads to a single change in one amino acid, a building block of a protein, and that can cause enough problems that you could have, for example, dysfunctional ABCD1 protein that can lead to a genetic disease like ALD. So, types of variants. Stefan Kemp, I'm not sure if he's still here, but he talked this morning about, hey Stefan, about VUSs, and but I think it's worth touching on really quickly. So, there's a whole spectrum of types of genetic diseases that you can see, or genetic variants that you can get. On one end of the spectrum is completely benign. The other end of the spectrum is pathogenic. If you have a benign or a likely benign change, what that means is that we see a change in the gene, but we feel very confident that this is not associated with human disease. And the other end of that spectrum is likely pathogenic or pathogenic, which we see a change in the gene, which can, maybe it affects the protein in a certain way. Maybe there's a family history of patients who have the same change that end up having symptoms, and we feel pretty good about calling it disease associated. That's a positive test, and that's and that identifies a new genetic diagnosis. In between those two is the variant of uncertain significance, and Stefan this morning talked a lot about that and some of the challenges that have come, maybe especially with newborn screening. But a VUS is just a change in a in a gene that we don't yet know which direction it's leaning. In general, in the field of genetics, VUSs tend to lean ultimately towards benign or likely benign, but I'm not sure we know that information yet in ALD. So then transitioning over from genotypes to phenotypes. So again, a phenotype is an observable trait. So the name Adrenoleukodystrophy tells you what the observable traits that you can see are in the disorder. Adreno means adrenal gland, leuko means white, specifically the white matter here, and then dystrophy, technically if you look at the etymology, means abnormal growth, but kind of in this context just means disease. So overall, adrenoleukodystrophy is a genetic disease that's associated with adrenal gland disease and white matter abnormalities. And just really quickly touching on the difference between gray and white matter, it's the signal to propagate efficiently. ALD was probably first described in 1910, but then the term adrenoleukodystrophy was officially coined in 1970 by Michael Blah when studying boys who had both adrenoleukodystrophy, had adrenal gland disease and also leukodystrophy. Okay, so cerebral ALD. Obviously, we've talked a lot about cerebral ALD, and everyone in this room thinks a lot about it. The phenotype of cerebral ALD is defined by white matter lesions on an MRI that are consistent with the pattern of ALD. You can have onset of those lesions in childhood. That's called childhood cerebral ALD. And if you're an adult that has lesions on your MRI, it's called adult cerebral ALD. We have a pretty good sense as to what the major high-risk times for developing cerebral ALD is. You can see on this graph here, the red is cerebral ALD. So kind of around 4 to 8, 4 to 10 is the highest risk period for developing it in childhood. But if you get out of that period, you're not necessarily out of the woods. In fact, there is a second bump in adulthood that you can see in your 20s to 30s. And that correlates with our recommendations for MRI screening, right? So if the highest risk region is from 4 to 8, then we will do our MRIs the most in that time. So from 2 to 12, you do them every 6 months, and then you can space it out to yearly thereafter. So clinical symptoms that come with cerebral ALD can be incredibly broad, and it just really comes from the area of the brain that is affected. So there are classic regions that are affected. For example, you can see in this picture here, the parieto-occipital region is affected, but depending on where is affected can affect the symptoms, and they can be very broad. And so Gerald Raymond came up with the NFS score, the neurologic function score, that helps us to more systematically quantify what those symptoms are. Oh, sorry, my neighbor's calling me. And we use this when we're determining eligibility for gene therapy. Contrast enhancement on MRI is an important part of the phenotype of cerebral ALD. So when you inject contrast into your veins, it circulates around in your bloodstream, and then it gets to the blood vessels in the brain. The vessels in the brain are special because they have the blood-brain barrier. What that is, you can see in this picture here, the blood-brain barrier is just the way that the vessel is organized. The cells that are lining the wall are very tightly packed together. They also have other cells. They're kind of like sticking their feet onto the edge of the vessel that helps to provide an extra barrier. And so this is important because it makes the brain very selective for what gets out of the bloodstream into the brain. But when you have cerebral ALD, there's an active inflammation that happens. And when you have inflammation, your blood vessels get leaky. When your blood vessels are leaky, the contrast that is injected into the bloodstream can leak out of the blood and go into the brain. And you can see that on the MRI. So on the left is pre-contrast, and in the post, you can see this white contrast that's enhancing the surrounding the white matter lesion. This means there's active disease, and this is required to pull the trigger on BNT or gene therapy. The LESS score we've talked about, I think, a lot in this conference. This is a score that we use to quantify disease severity in MRI. To qualify for gene therapy, you have to have a LESS score of 0.5 to 9. Okay, switching over to AMN. So if you break down the word AMN, or adrenomyeloneuropathy, adreno again means adrenal glands, myelo means spinal cord, neuro means nerve, and pathology is disease. Caveat here is that we do not refer, when we say AMN, we're not referring to adrenal gland disease. The term was originally coined in 1977 when Griffin's group was studying 4 males that had adrenal insufficiency in childhood and then developed AMN in their 3rd decade. But when we say AMN, we're referring to the spinal cord peripheral nerve version of the disease. Sometimes confusing there. So AMN, well, cerebral ALD is defined by lesions on MRI. AMN is defined by signs and symptoms, so not imaging. And that's very important. So I think a lot of people in this room are familiar with the signs and symptoms of AMN. This can include spasticity, they can include difficulty walking, pain, sensory changes, issues with the bowel and bladder, so constipation, diarrhea, incontinence, etc. And in men, we get symptom onset, or they get symptom onset usually in their 20s or 30s. Again, this is based on signs and symptoms. I'm not sure if I said this, but a symptom is something that a patient experiences, and a sign is something that a physician or a provider elicits on physical exam. So signs that we look for largely relate to signs that are related to spinal cord disease. There is some signs you can see that are related to the peripheral nerve too, but they largely have to do with the spinal cord. So when the brain is sending a signal, for example, to your muscle, there's two major neurons that are involved. The one that comes down from the brain and travels through the spinal cord is called the upper motor neuron, and the one that goes from the spinal cord to, for example, the muscle is called the lower motor neuron. And when the signal comes down from the brain, from the upper to the lower motor neuron, it tells the neuron what to do, but it kind of has a mechanism in place that kind of keeps the signal at bay. If you have white matter disease or spinal cord disease in AMN, then you lose kind of that brake on the lower motor neuron, and that can lead to excess activity. So that's why you get too much muscle contraction. There's too much signal that's coming from the nerve. That's why when you check your reflexes, the signal that comes back that makes your reflexes very brisk is coming from that lack of the kind of checkpoint. So that's why we pay attention to muscle tightness, spasticity, brisk reflexes, which we call hyperreflexia. Sensory changes, of course, you can see. Gait changes, you can see. And then the upgoing toes, it may seem arbitrary and weird sometimes when we check whether your toes are upgoing or downgoing, when we kind of scrape the bottom of your foot. The reason why we do that is that there's a newborn screen called, a newborn exam finding called a Babinski sign, or if you kind of tickle the bottom of the foot in an arch, you should see the baby's toe go up and the rest of their toes fan out. That just means that the baby's white matter is still developing. For a baby, that's completely normal. For an older child or an adult, that's abnormal, and that indicates the possibility of white matter disease. So that's why we pay attention to that. Okay, adrenal insufficiency. So the adrenal gland is sitting on top of your kidneys, and it's important for releasing cortisol and aldosterone. Cortisol helps maintain your blood pressure and your blood sugar. Aldosterone helps to maintain your salts and your blood pressure. And really what this is for is to mediate the stress response. So if your body is under some sort of stress, whether it be an infection or an illness or a vaccination or you're under anesthesia or something like that, your brain tells your pituitary to release ACTH, which tells the adrenal gland, hey, we're in a stressful situation. We need to release cortisol, and then the cortisol helps you fight off that response. Now, if you don't have working adrenal glands, which is what happens in adrenoleukodystrophy, then when your body is under stress, it can't compensate with the cortisol and to a lesser extent the aldosterone. And that's why we give back the hormones. And it's actually pretty straightforward to treat. So the signs and symptoms of adrenal insufficiency, if you can't maintain your blood pressure and your blood sugar quite as high, you may feel kind of weak, fatigued, lightheaded, dizzy. Your blood pressure and your sugar will be a little bit lower. It can present with kind of nonspecific GI symptoms that often get misdiagnosed as a GI bug. And the most kind of life-threatening manifestation of this is an adrenal crisis. And what that is you got a really significant stress around your body, and you cannot fight it off, and that's when your blood pressure drops and you go into shock and you end up in the ICU. And that's the reason why we pay so much close attention to the adrenal glands in ALD, and that's the reason why, and one of the reasons why it's on the newborn screen. We also talk a lot about pigmentation of the skin, and it's a quick point about that. When your brain's telling your pituitary gland to make ACTH, and the process of making the ACTH, which is going to tell your adrenal glands to work, there's a little side pathway that produces a hormone called melanocyte stimulating hormone that then tells your body to make more melanin in your skin. And that's actually why you get hyperpigmentation or darkening of the skin in adrenal insufficiency. So we test for it in the lab. Because the adrenal glands are not working, you can't make cortisol, that's low. The ACTH is trying to make the adrenal gland work, so it's elevated. And so check that routinely. Your endocrinologist will as well. You can also inject a synthetic form of ACTH and then test to see how the cortisol levels rise. And that's often the way that adrenal insufficiency is diagnosed. So cerebral ALD is MRI, AMN myeloneuropathy is signs and symptoms. Adrenal insufficiency is diagnosed when you have lab evidence of it, plus or minus clinical symptoms. And then also, very importantly, your endocrinologist decides that you need to be on steroids. And that's where AI kind of differs from the rest of the phenotypes. All right, transitioning over to women, again, just an incredible outpouring of pictures from the community. So I wanted to make sure I included all of them. That's really great. Thank you all for doing that. Thank you to Christy for sending them over to me. So we talked about this in the women's group, the breakout session, but we're moving away from using the term carrier in ALD. The reason why we don't want to use the term carrier is historically and classically still in genetics, a carrier is someone who has a change in one of two copies of a gene, and in that situation, you do not have symptoms. Now, it's understandable at first that we said carriers are women in ALD because they have two X chromosomes and one of them's affected. But because of the way that the X inactivation happens, and because we know that women absolutely, in general, become symptomatic with time, we don't want to use that the term carrier. We actually had one of our, in the meeting we were talking about, there's been bad experiences where physicians even have said, all of these symptoms are in your head, you're just a carrier of this disorder. That's absolutely not true. So we're trying not to use that term. But, women get myeloneuropathy the vast majority of the time, very rarely cerebral ALD and AI. And you can see in this picture right here that with time, the majority of women absolutely do become symptomatic. Like in the 60s to 70s, 88% of women will have myeloneuropathy symptoms. But because of the difference in the sex chromosomes, their onset is later, which you can see in this picture here. This is a little bit of an excerpt from York Jaspers and Stefan Kemp's recent paper. I don't have enough time to go into it, but essentially, kind of what I've already talked about, which is that women get myeloneuropathy, so spinal cord peripheral nerve disease, while men, they very, very rarely get cerebral ALD and AI. There's a lot of really cool emerging literature here that shows that perhaps the women that get cerebral ALD and AI are the ones that are skewed the most in the direction of manifesting the abnormal copy. So the final phenotype to talk about in ALD is asymptomatic, and that's an important one to remember. I thought I'd talk a little about a couple things that are also misdiagnosed as ALD. So it's normal for the first 2 or so years of life for the white matter in your brain to still be developing, so you can see changes on the MRI when you do that. There's the last region of the brain that changes in that time. It's called the terminal zone of myelination, and that's shown in this middle picture here. The thing that's tricky about the terminal zone of myelination is that it's in that same region that's one of the classic regions of ALD, which you can see on the picture on the left. So when you see this white matter smudge in that area, it's very important to think about the age of the child. Also, with time, you can see the kind of nonspecific white matter changes on MRI. And so shown on the right here is just a little random white dot that was seen in one of our patients. That does not mean that patient has cerebral ALD. Similarly, if you have a little mild bump in ACTH, but your endocrinologist decides you do not need to be put on steroids, that's not adrenal insufficiency. And then even though we do get MRIs of the spine often in our patients in clinic, again, AMN or myeloneuropathy is only diagnosed on signs and symptoms. So this is a quote that I heard in a conversation with a patient I was seeing with Dr. Eichler was, Dr. Eichler, I thought I have AMN. You're telling me I have ALD and AMN. Which one is it? And I think this points to the important kind of difference between genotypes and phenotypes. So the overall genetic diagnosis is adrenoleukodystrophy, but the phenotype is based on the symptoms that you have, and that would be AMN in this case. So taking all that in consideration, I think worth pausing for a second to talk about how an incredible amount of research progress that we've made in the field in recent decades. We have identified the molecular genetics of the ABCD1 gene, and we know about the very long chain fatty acid biochemistry. We have the ABCD1 variant registry. We have newborn screen. We have international recommendations and guidelines for treatment. We have gene therapy for cerebral ALD, and we have so much incredible research that's happening now. But despite all of that incredible research, there's still a lot of fundamental questions that are left unanswered in ALD. And a lot of that comes from the significant variability in the symptoms that you experience or in the phenotypes. And so we have generalizations, and you can see in this picture here, the y-axis is a little confusing, but just bear with me that what this is showing is in general, we know that adrenal insufficiency tends to be the thing that shows up first, and then maybe it's cerebral ALD, and then eventually in adulthood you get AMN. And we have those trends for like the high risk regions or time periods for cerebral ALD. But, there's not any hard and fast rules, and we don't have a crystal ball. I wish when patients came into clinic, they say, what's going to happen to my child? We could tell them that they're going to develop adrenal insufficiency or not. They're going to develop cerebral ALD. Men will get AMN, but other than that, we really can't make any accurate predictions because not everyone gets all of the symptoms, and the order in which they get it can vary quite a lot. So I think that highlights the important point, which is that phenotypes are not static. Phenotypes evolve with time, and they're very, very dynamic. You can start asymptomatic, as everyone does, and then develop AMN or adrenal insufficiency or cerebral ALD. You can also develop phenotypes simultaneously, particular phenotypes. And so that brings me to research that we're doing at MGH. It's called Evolutions in Phenotype in Cerebral ALD. So this is just very preliminary data. I just want to show you that we're working on it. We have a cohort of 350 patients, and we're trying to characterize their phenotypes and then with time and see if we can answer some more interesting questions, right? So the questions that come to mind is, if you have adrenal insufficiency, is that associated with a higher risk of having cerebral ALD? If you develop AMN early in your life, does that mean that you have a higher chance of developing adult cerebral ALD? Also, what's the average time that it takes to evolve between phenotypes? So with this data set, we hope to be able to start to answer these questions, and thinking about the clinical nuance can maybe answer some of those questions. Finally, hoping that we can take this database and the kind of nuanced clinical presentation and correlate it with some of the amazing precision medicine research that we have. So the lipidomics work that just came out from Stefan Kemp's group. Troy Lund talked to us about neurofilament light chain. And then also Patty Mussolino's group is looking at brain perfusion MRIs and angiogenesis markers to predict cerebral ALD. So we hope to do with all this is better predict individual outcomes, develop more individualized screening protocols, and then maybe enhance trial design. So in the interest of time, I'll skip the summary slide and just say thank you.
Thank you. All right, I already see one question.
I just want to thank you so much for that. That was so informative. I've been trying to figure this out for 25, 45 years, and I'm going to be watching that more than once. So thank you.
I want to second that, and I feel like this needs to be given to so many doctors and all the newborn screening families. I wish I had had this
Thank
17 years ago.
Oh, as far as slides, as I understand it, we'll make the slides available, just not right now, but we'll make. Oh, the recordings. Okay, yeah. So it will be available.
I can also just send them to you if that'd be helpful as well.
Here's his email. Send Dr. Thompson email, and he will send you the slides.
Sorry, I ran a little bit over time. The yellow thing I didn't know was going to be, that threw me off for a second. I was like, I'm not sure how much time I have left, but anyway. Any other questions?
No other questions? Or no, this. What?
Oh, it sure is. Yes. I thought I made
Thompson.
it through with zero typos, but the second to last letter of the entire presentation. Yeah. Yeah, it's definitely ORG at mgb.org.
Oh, yeah, ORG.
Thank you for catching that.
Yeah, that's a really good way. When people give fake numbers at a bar, that's what they do. Yeah, just email me.
Yeah.
It is ORG. Thank you for a
Thank
great
you.
presentation.